In order to minimize costs associated with lower limb overuse injury, the director of the Medical and Allied Health team of a sports club would like to screen players in order to initiate an injury prevention program. The director has asked us to outline risk factors for the development of hallux valgus, which our team will now present. Hallux valgus is a forefoot deformity affecting the first ray of the foot, which is characterized by the progressive angular deviation of the hallux. Evolving over several stages, this bony pathology begins with a lateral deviation of the great toe and a medial deviation of the first metatarsal. According to Wynn, this common pathology is characterized clinically as an angular deviation of the hallux greater than 15 degrees towards the lesser toes when measured against the line of metatarsal bones. The development of hallux valgus is highly debated, but it is speculated this pathology results from an interplay of extrinsic and intrinsic factors. Genetic predisposition is thought to play a role via inheritable biomechanical characteristics including, but not limited to, arch height, foot range of motion, and osseous alignment. Furthermore, gender, age, foot posture, ligamentous laxity, and body weight are also thought to pose intrinsic risk factors, compounded by major extrinsic risk factors like poor footwear and excessive ground reaction force. According to Pereira, Mason, and Stevens, the pathology changes associated with hallux valgus are thought to occur in stages in the presence of one or more intrinsic or extrinsic risk factors. After the foot, or more specifically the first ray, is predisposed to a HAV risk factor, the first stage in the pathogenesis of hallux valgus is a gradual failure of the ligamentous medial structures that play a key role in maintaining the structure of the medial longitudinal arch. The first MTBJ is stabilized at the level of the joint capsule by structures including the medial sesamoid and medial collateral ligaments. Failing of these structures predispose the first metatarsophalangeal joint to greater ground reaction forces. Increased ground reaction forces beneath the first MTBJ joint gradually causes the first met head to drift medially and slip off the sesamoid apparatus, where it becomes subluxed on the fixed hallux, but still attached to structures including the deep transverse ligament via the plantar plate and the abductor hallucis tendon. Subluxation of the hallux causes adductor hallucis, flexor hallucis longus, and extensor hallucis longus to bowstring laterally. This provides these muscles with increased mechanical leverage to slowly pull the hallux further into valgus. The first MTBJ joint capsule is not being reinforced by any strong ligamentous structures following this trauma. The displaced muscles and tendons will continue to abduct the hallux until the distal phalanx angles into the neighboring second digit. In their respective studies, Menz and Wynn proposed two features of high-heeled footwear that predispose women to the development and progression of hallux valgus. The first feature proposed by Menz is that high-heeled shoes are simply too narrow in width, particularly in the area of the toe box. This results in the constriction of the digits that are squeezed into the shoe and forces the hallux into an abducted position. Constant lateral deviation of the hallux leads to the formation of hallux valgus. The image on this slide is an example of narrowness of a high-heeled toe box versus the actual width of a wearer's foot. The second mechanism by which hallux valgus is thought to occur is described by Wynn, who proposed that wearing shoes with heels greater than 25 millimeters results in a medial shift in pressure under the foot. This medial shift creates an increased ground reaction force beneath the first MTBJ, resulting in biomechanical alterations to gait and subsequently the progressive development of hallux valgus. A systematic review and meta-analysis examining the prevalence of hallux valgus in the overall population and in age and gender subgroups was performed by Nick Smith and Vicencio in 2010. The results revealed hallux valgus was 2.3 times more prevalent in female populations than in males. An association between the prevalence of hallux valgus and an increasing age also was reported, with a prevalence of 7.8% in juveniles, 23% in adults, and 35.7% in the elderly. In order to develop a structured research question, we used the PICO method. The population, or patient group, was labeled as older females. The intervention was designated as the wearing of high heels. The comparison group was characterized as the wearing of shoes with no heel elevation, and the outcome was identified as the presence of hallux valgus. But combining these elements together, we then formulated the research question. In a population of older females, does a history of wearing high-heeled shoes in comparison to wearing shoes without heel elevation contribute to the development of hallux valgus? We looked at two articles which investigated whether there was an association between wearing high heels and hallux valgus. The first study was conducted by Menz and Morris in 2005, titled Footwear Characteristics and Foot Problems in Older People. The second study, titled Factors Associated with Hallux Valgus in a Population-Based Study of Older Women and Men, the Mobilized Boston Study, was published by Wynn in 2010. Critical appraisal was conducted for both studies in order to determine the study level of evidence. In the study by Wynn et al., information such as age, sex, race, education, and types of shoes worn at specific ages was gathered from subjects participating in the first cycle of the Mobilized Boston Study. Physical examinations were undertaken to determine the height and weight of participants. Feet were also assessed for the presentation of hallux valgus, and foot pressure data was collected. This information allowed researchers to examine possible association between hallux valgus and variables such as the past use of high-heeled shoes. Similarly, Menz and Morris gathered information from residents of an Australian retirement village via questionnaire. Furthermore, a clinical assessment and footwear evaluation were undertaken whereby shoe elevation was measured along with length, width, and area. Participants were also questioned on their past and present use of high-heeled shoes, and the Manchester scale was used to determine current HAV severity. Researchers used this data to draw associations between the type of footwear worn by participants and the presence of foot deformities such as hallux valgus. Using the levels of evidence guidelines published by the NHMRC in 2010, we identified both studies as cross-sectional. According to NHMRC levels of evidence guidelines, cross-sectional studies rank as level 4. This type of study is useful for a hypothesis generation and to identify whether a risk factor is associated with a particular outcome. However, they cannot infer causality, as a time dimension was not included in either study. To investigate any theorized associations, cross-sectional study participants are assessed at a particular point in time, or cross-section, and data collected on outcomes relates to that point in time, as was the case with both of our chosen studies. The key findings of the study conducted by Wynn revealed that 58% of females had hallux valgus. Women who reported to have worn high heels as their usual footwear between the ages of 20 and 64 were found to have a 20% increased likelihood of having hallux valgus compared to women who did not wear high-heeled shoes on a regular basis between the same ages. This was indicated with a 95% confidence interval of 1.5, and a p-value of 0.04. The results of Menz and Morris study revealed that ill-fitting footwear alone were inadequate width of indoor shoes and inadequate width and area of outdoor shoes were associated with a moderate to severe hallux valgus. Given that a narrow toe box, regardless of heel elevation, is a theorized mechanism of HAV deformation. This finding is relevant to our PICO question. Furthermore, a heel elevation of over 25 millimeters was found to have a statistically significant association with the hallux valgus in female participants, with a p-value of less than 0.05. The odds ratio for this association was found to be 2.48, with a 95% confidence interval of 1.02 to 6.04. There was no significant association made between foot problems and past history of wearing high-heeled shoes. We use the NHMRC levels of evidence and grading tool to determine whether we can apply these findings to our target population of sports players. Both studies were rated as level 4 evidence or poor and were graded D. Whilst level 4 studies cannot infer causality, the cross-sectional study designs does allow for associations to be made. In both studies, it was observed that women who wore high heels or shoes with a heel elevation greater than 25 millimeters had an increased likelihood of having hallux valgus. Whilst both studies rated poorly for levels of evidence, both revealed consistent findings and were able to show statistically significant association between hallux valgus with a history of wearing high heeled shoes. Because both studies were able to explain inconsistencies and discuss study limitations, they were graded a B. Generalizability was graded a C. Both studies comprised of elderly participants aged 62 years plus, which is in contrast to our target group of younger athletes in the sports club. The association between hallux valgus and a history of wearing high heels was statistically significant in both studies and is clinically sensible to apply these findings to our sports population. The applicability of the association between hallux valgus and high heels was graded C. The association between hallux valgus and high heels was identified. However, the low study qualities and population differences mean that this association must only be applied to sports players with caution. Our final recommendation to the director is that whilst wearing high heels has not been identified as a risk factor for the development of hallux valgus, there's a strong association between the two. As such, players who show signs of hallux valgus should be seen by a podiatrist for footwear assessment, management, and education.